us. And I hope that everybody is okay, because we'll be recording this webinar, because I think we're going to have some really interesting discussions, and really want to be able to share that after the webinar as well. So I hope everybody is okay with that. And yeah, so welcome. This is a webinar that is jointly being hosted by the ARISE Consortium and Chorus. And both of these research consortiums are working on issues around health and well-being in urban areas. The structure of today's webinar, we have just 1 hour, so we're going to keep to time as much as we can. So I'm Helen Elsey. I'm a prof in public health at the University of York, and I'm lucky enough to work with both ARISE and with Chorus. We will start with some quick presentations, 10-minute presentations on the ARISE framework that has developed out of the ARISE work to understand intersectionality and gender issues within informal settlements. And Laura Dean will be presenting that. And we'll then hear from Sushama Kannan, who is from ARC Foundation in Bangladesh, who will be talking about the framework that we've used in Chorus to understand intersectionality and gender issues. After those presentations, we will have a panel discussion with researchers from across the partners from ARISE and Chorus. And you can see here the great spread of partners that we have from both consortia, from Kenya, from India, from Bangladesh, the UK, Sierra Leone, and from Chorus, from Bangladesh, Nepal, Ghana, and Nigeria. So we have a real range of perspectives on gender and intersectionality issues from a number of different contexts. So I think this is going to be a really interesting discussion. I would ask that you put your questions and comments throughout during the Q&A, in the Q&A section on your screen. And there will be a moment to ask questions of clarification after the 2 presentations, firstly from Laura and then from Sushama. And then after the panelists have had a chance to really talk through how they've used the frameworks and implications for policy, there'll be another chance, if we don't run out of time, for us to respond to some questions from participants. And I will talk you through the speakers as we move on to the panel discussion. But you can see their lovely faces there, and the range of researchers and contexts that we have represented today. Yeah, we have to acknowledge our funders for both the research consortia. So I think, without wanting to take up any more time, I will hand over to our first presenters, and we will start with Laura talking through the framework that has come out of the ARISE work. So Laura, if I could hand over to you, I will stop sharing my screen, and if you could go ahead and share your screen and hand over to you.
Let me.
Brilliant. Thanks, Laura.
Thanks a lot, Helen, and thanks everyone for being here. As Helen said, I'll present to you on behalf of the ARISE Hub, and specifically the Health and Wellbeing group, who work together. We've developed this kind of approach to equity analysis. So firstly, I just wanted to give you something to think about as we move through today's webinar. So inequities are all around us, and some are easy to see and some are less visible. On this slide are several pictures that I obtained from a quick Google search this morning, and these pictures emphasize just how divided our cities have become. And I was with a colleague recently in Sierra Leone, and they explained to me how they'd not really noticed or considered many of the informal settlements they passed each day on their way to work. And in fact, I myself hadn't noticed those which I could see from my hotel window. And so my question to you as we go through this presentation, and perhaps as you travel home tonight, is when did you last notice the way in which social and structural inequities are often so visible, yet ignored within our societies? So within Arise, we're really focused on trying to recognise these inequities and work with organisations of slum dwellers as well as different institutions to change these and challenge these inequities. We're particularly focused on tackling inequities within and between informal settlements and recognising that not all experiences are the same. But how do we do this, and what's our approach to equity analysis? Largely speaking, within Arise, we focus on a social determinants approach, which aims to unpack dimensions beyond the biological and to draw attention to political, environmental and structural factors that underlie health and illness. And so what that means is we need to begin with the recognition that interconnected dimensions of daily life in informal settlements increase vulnerability to a wide range of health and psychosocial challenges. Commonly recognised dimensions included risks of infectious disease due to crowded housing, poor ventilation, lack of water and sanitation, as well as air pollution. But perhaps less well recognised is the emerging burden of non-communicable and chronic disease and mental distress related to issues around food availability, insecurity and violence, including gender-based violence. Of course, all these health issues are then exacerbated by a lack of access to quality healthcare, which can be financial, social and geographic. But what we've been talking about so far are the proximal factors underlying the risk of ill health. But for a social determinants approach, we need to really go deeper and ask why the circumstances of daily life are this way. And so within Arise, we try to think about this and link our discussions around equity to informality. And informality can be understood in many ways. A simple definition is a kind of settlement or economic activity that's outside the realm of the legal, formal institutions and processes of the state. It doesn't mean it's illegal, but often it can be. And so why is it outside? And it's normally because informal settlements have been a result of the state being unable to meet the basic rights and needs of people that are either migrating from rural areas, or it might even be as a form of survival for the urban poor, to create spaces of entrepreneurship. And so the problem is fundamentally one of unequal power relations in society that deny people their human rights and entitlements to realise their health potential, largely as a result of structural violence. And within Arise, we're trying to focus on tackling issues that the social and political systems have in place that shape these issues. And that means ultimately addressing issues of structural violence. But this is challenging to do. And one of the main critiques of structural violence is that it's a challenging framework to use on its own to consider issues of health equity. So alongside a consideration of the role of structural violence in shaping the politics and processes of informality, within Arise, we also draw an intersectional theory that is inherently gendered to help us unpack these challenges. Intersectional theory allows us to recognise that there are many underlying inequities within informal spaces themselves that shape challenges and possibilities for health that people face. For example, there's a large range of inequities which intersect in different ways and in different contexts at different times. So the influences on the health of a woman working as a waste picker in India will be differently shaped from those of an older disabled man in Kenya, for example, although they both experience exclusion and deprivation caused by class, caste, and based on economic inequalities. These are experienced in different ways due to their social positioning and including as a result of their gender. Within Arise, we're interested in how to create social movements and agendas that are inclusive of those diversities. We had to begin to think about how merging of these different concepts and theories can support us to operationalise consideration of key factors that contribute to health and equity in the settings where we work. And largely, how do we emphasise the role of violence in its visible and invisible forms alongside gender and intersectionality theory to allow for practical application of complex academic terminology in a real world setting? So collectively within our Health and Wellbeing Working Group, we've come up with the following framework. And our analysis of inequities stems from the application of these combined social and anthropological theories to document the inequities that within the lived experiences of the urban poor, who are both living and working informally to support the advancement of collective action. Specifically, we think about how three interconnected forms of violence interact to shape multiple and compounding layers of violence within the lives of people living and working informally. So as I said before, we utilise the theory of structural violence to consider how political, economic and social inequalities can both cause and consequence of poor mental and physical health. And we consider this form of violence largely to be the type of violence that produces violence. And we try to analyse how larger level structural factors really shape the micro level social processes that create visible violence in the everyday lives of people and shape both their emotional and physical health. We then think about symbolic violence as an entry point to consider how implicit inequities such as sexism, racism and ethnocentrism can contribute significantly to poor mental and physical health. We think about how symbolic violence largely becomes an internalized process as a result of social domination to which many people who live and work in informal spaces are subjected to as a result of their age, gender and caste. We try not to think about this form of violence to limit agency. Rather, it must be recognised and considered to enhance spaces of collective action. When considering symbolic violence, we also note that the domination of the dominant by the domination means that sometimes, in the case of patriarchal advantage, for example, men can be dominated by the cultural and social expectations of masculinity and subconsciously try to live up to ideals of what it means to be a man. And this helps us to consider how individuals negotiate their own roles of the dominator and the dominated within larger political, economic and social systems. Finally, we think about everyday violence or behavioural acts intrinsically connected to symbolic and structural violence. However, this form of violence allows us to think about how some acts of violence become repeated so often that they become routine, and if kept hidden or unaddressed for long enough, frequently become normalized as part of an individual's everyday experience. However, as I said before, we recognize these forms of violence don't influence all individuals in the same way. Rather, they intersect with individual identities, which of course themselves constituted by intersections of things like sex, age, gender, and economic status, to shape nuanced experiences and outcomes for individuals within specific populations or subpopulations. So within ARISE, we centre intersectionality as a critical underpinning theory. We also recognise the importance of intersectionality as a theory in influencing how people facing multiple intersecting exclusions and marginalisations can organise to question the ideologies that justify inequities, as well as contesting their institutional and material bases. And so by merging these theories of violence and intersectionality, we're able to consider how varying forms of violence interact and are mediated by characteristics at the micro or individual level to create specific and nuanced experiences of health and social inequalities. The addition of intersectionality theory was essential to operationalise theories of violence to consider how individuals' micro-positioning within broader macro, structural and social processes shapes their specific responses to health and illness, and how this varies through space and time. So the case studies that you'll hear about from ARISE today begin to highlight our application of this framework and form part of an intracategorical intersectional analysis, which means they allow for consideration of the specific experiences of key subgroups within larger social categories. And an example of this that you will have seen before is Crenshaw's analysis of Black women's experience within a white feminist discourse. So the case studies that are considered are presented here on the screen. And these specific subpopulations and case study groups were identified as those who were particularly marginalised through the use of participatory methodologies. And so that's why these case studies kind of came together to shape our intercategorical analysis. So just to finish again by acknowledging our funder, but particularly the Arise Health and Wellbeing Working Group, who've really worked together over 3 years now to develop this equity framework together.
Fantastic. Thank you, Laura. That was really insightful and incredibly helpful, I think, to see that framework that you've used within Arise. Can I just ask all participants, as you're listening, please do put your any questions and comments in the Q&A, and we can come to them after the 2 presentations. Right now, though, I would like to move on to our next presenter, who is Sushama Kannan from ARC Foundation, who is going to be talking about the framework that we've used to support work in Chorus. Thank you, Sushama. Over to you.
Thank you, Helen. Am I audible clearly?
Yes, that's absolutely fine. Very clear.
Okay. Hello, everyone. My name is Sushama Kannan, and I work as a research fellow in ARC Foundation. In Chorus, I led an action learning group on gender and intersectionality.
Sushama, if you could speak up a little bit, it is a little bit faint. Thank you.
So the content of my session is a brief introduction to Chorus, how gender and intersectionality have been addressed in Chorus. We have used Morgan framework. So I will talk a little bit about Morgan framework and how the framework helped Chorus researchers. So the full form of Chorus is community-led, responsive, and effective urban health systems. It is a 6-year FCDO-funded research program, which has been started in 2020 and will continue till 2026. And there is a collaboration of 7 organizations across 5 countries. The organizations are, you have seen, University of Nigeria, University of Ghana, ARC Foundation and Black James P. Grant School of Public Health from Bangladesh, and Heart International from Nepal. In Chorus, we aim to strengthen the urban health system by linking across the plurality of providers, multi-sectoral collaboration, responding to the double burden of non-communicable diseases and communicable diseases, and identifying, reaching, and engaging urban poor. And these 4 aspects are the pillars for Chorus. One of the expected outcome of Chorus is to co-produce gender responsiveness and pro-poor intervention. And to achieve this outcome, there is an interlinked 5 stages plan, which is being implemented in all Chorus countries. In stage 1, a need assessment and solution generation activity took place with community. Concurrently, in stage 2, analysis of existed data, literature, and policy was done to find out the gap. In stage 3, currently we are co-creating the health system intervention with community service providers and policymakers. And the next stage will be to implement the intervention. And in stage 5, all countries will evaluate the effectiveness, cost effectiveness, and impact of the intervention. So the first 4 large projects of Chorus in each country, they are looking at different aspects of health. So in Dhaka, Bangladesh, they're looking at strengthening urban primary healthcare system to deliver essential NCD care. In Nigeria, they are developing and institutionalizing health system linkages between formal and informal sector. In Ghana, implement and evaluate a package of interventions that enable sustainable provision of life cycle health promotion. And in Nepal, understanding the mechanism needed to strengthen primary care delivery for NCDs for urban poor. So how gender and intersectionality was viewed in Chorus? We have seen that within all the Chorus cities, it is the individual and community identities which determine the health outcomes and the health behaviors. And these health outcomes and health behaviors are underpinned by exposures and access to quality healthcare. These are again further shaped by wider social, political, and economic structures and norms. Moreover, as Laura already have said previously, when gendered identities intersect with other social stratifiers, that also results in inequity in health and well-being. And the examples of other social stratifiers which are given previously are disability, ethnicity, religion, caste, socioeconomic status, etc. Another factor is rapid urbanization. So rapid urbanization also changes gender and social norms. It also transforms patterns of discrimination and disadvantages. These discrimination and disadvantages, they also create inequity in health system. However, these inequities are often so ingrained and also so embedded within societies, within structures and systems, that you often become blind to their existence, and thus it remains unchallenged. These inequities can be seen both within health systems and within our own research organizations. Identifying and addressing these inequities is a core principle of the CHORUS Research Consortium, and that's why we are focusing on gender and intersectionality to incorporate in our research as well. So to ensure that we are addressing gender and equity within our research and our consortium, we have established an action learning group in CHORUS, which is focused on gender and intersectionality. This group has a core group of 8 to 10 members from all CHORUS partners. This group meets usually monthly, and it allowed the members to share their previous experience of gender and equity work, highlighted the extensive experience across the team, and share with all others. To help all the researchers in CHORUS, the ALG members have developed a gender and intersectionality guideline, which you can find in CHORUS website. This guidelines aims to help the researchers across CHORUS to identify approach for how to address the gender and equity aspects in their project. There are several gender and intersectionality frameworks researchers can follow or adopt for their study. So we have used Morgan framework in our guideline, which I'm presenting in next slide. This framework was developed by Morgan et al. In 2016. These frameworks can help researchers to organize their thinking, to develop gender-sensitive research questions, to develop data collection tool. It can help during sampling, data collection, analysis, and write-up. It helps to ensure that gender and intersectionality are incorporated throughout all phases of the research process. If you see the framework, it has some domains, and researchers need to ask a set of questions in those domains. The framework helps us to consider gender as a power relation and driver of inequity in health systems. It identifies how power can be constituted and negotiated in the context where we work. So the first set of questions focuses on access to resources by asking who has what. The resource might be money, transport, healthy food, or any other resources that influences health. The next question is who does what? This question guides us to consider the division of labor and about everyday practices. This could include how caring responsibilities or working outside the home influence access to care. Then we need to consider how values are defined. What are the social norms? What are the ideologies, beliefs, perceptions that control how people live? Finally, who decides? What are the rules and decision-making process that regulate health and health-seeking behavior? And the next section looks at how norms can change by considering how power is negotiated among individuals and institutions, also within wider society. What are the individual power relations within households? So this could be across genders and also as they intersect with different social stratifiers. Then we need to consider the institutional and social levels and think through the power dynamics between different genders according to relevant strata. All of these domains can change because of the social shift and power relations that happen within health systems. So considering the factor that influences these changes and the way how the changes happen in the past can help us to identify strategies and action which can help to bring equity through our research. So the last discussion is how the framework helped chorus researchers. Ideally, the framework can be applied at each stage of the research. However, we are pointing out to 3 major stages, which are during conceptualizing or designing the research, during developing data collection and actual data collection, and also during analyzing data and producing output. However, in research, we did not follow the framework mechanistically. Rather, our use of the framework was evolving in nature. Although the framework was not used during conceptualizing the projects because our projects were not solely gender focused. So during developing data collection tool, the framework helped us to think about asking questions in a way that can explore the influence of gender and other stratifiers for the aspect that is the particular research is going to focus. For example, in Bangladesh, it assisted researchers to think about sampling, and they include the third gender as well to know about their health-seeking behavior and how the systems provide them healthcare. The framework was used to more understand the influence of gender and their social stratifiers in accessing and providing healthcare services. It helped inform the analysis and teases out the information considering different domains of gender, which might have been overlooked if we haven't used the framework. We categorized and coded the information under different domains of the gender framework and also looked at cross-linkages between domains. It also sensitized the aspects that should be looked at to understand the inequities, taking gender as an entry point. It also helped us to develop our output as well. We have presented our preliminary findings on gender and intersectionality in terms of provision and accessing healthcare services in urban conference of International Conference of Urban Health in 2022. And there is also a case study and blog has been published on the findings, which are also available in Chorus website. And we also arranged a webinar for Chorus researchers on how to use the Morgan framework in their project. And that was all about it. Thank you so much.
Thank you. Thank you so much, Samshona. I think that was really helpful, and great explanation of how to actually kind of practically use a framework like this at all the stages of the research, and how Chorus has sort of done that in not a sort of mechanistic way, but really adapted it to the different research questions and projects. So thank you so much for sharing that. We have a couple of questions in the Q&A, and really interesting to see. And so we've got a question around which gender frameworks are there any that have been specifically developed to address health in urban areas? Any experiences of working with ministries of gender and or ministries of gender or ministries of family, and some really nice reflections on the frameworks. So if I can ask our panelists to keep looking at the Q&A, and please do type your answers to any of those questions. And we can come back to them at the end after the panel discussion as well, I think. But in the interest of time, it would be great now just to turn to all of our panelists and ask them to really reflect on how they've really applied these frameworks within the work that they've been doing. So I was just trying to share my screen so you could see the all of our panelists. So I'm hoping you can see that. It seemed to disappear when I put it on. Oh, there we go. That's better. So Yeah, I would like to start by asking, and I think I'm going to go in no particular order, but just following the photos of our speakers on the screen. So Abriti is a senior researcher with lots of experience on gender and qualitative research from Herd International in Nepal, working with Chorus. And I'm going to ask each panelist to talk through how using these frameworks has really helped them to understand health outcomes, health behaviours within the city context where you've been working. So Abriti, if I can turn to you first, would you like to just explain a little bit about from the work that Herd has been doing, how the framework, what kind of insights have you got from using that framework?
Thanks, Ellen. Hello, everyone. Thanks, Ellen, for this opportunity. Yes, I think as Susma and Laura has mentioned, like how the framework has been helpful. So it's the same with us, like when we use this Morgan framework to actually guide our like need assessment study under Chorus project. So this actually has helped us to understand and look through how the gender differences across various domains and also across different social determinants have actually influenced or shaped the experiences, opportunities, constraints, and power to seek healthcare within the urban poor context. For example, if we take the findings, or if we reflect back on the findings from the study, then we found that there was a variation in the type of health facilities that urban poor visited, which was also determined by the gender and other social dimensions such as age, occupation, economic status, among others. So mainly, we could see the intersection of the gender and occupation often within the urban poor context, where most of the urban poor were daily wages workers, and they had limited time availability to go and visit the health facility and get the services, which means the availability and accessibility of the health services was one of the important factor that actually determined the health-seeking behaviors of the urban poor. So, for example, they mentioned like they prefer going to the health facilities, or let's say even to pharmacies or to private clinics, which are nearby to save time, because they don't want to lose the time. They don't want to go off work and like not earn their or some amount to get the services, rather than going to the health facility, government health facility, where the services could be available for free of cost or at a minimal cost. But then like you might end up like not having time to go back to your work, to the work, and then like spend more time at the health facilities. And when it comes to women, the gender norms which shapes the dual responsibility of doing the household chores and also earning, then the situation is more difficult and different. And as they have to like manage both the responsibilities, they again prefer they again prefer going to the facilities nearby. So this is one example where we could see like how the factors has influenced the health, how the occupation, or let's say the gender has influenced how they influence the choices they make in terms of seeking health care services. So it seems like it would be important to look at these factors and understand the intersections within the urban poor context if we really want to reach the unreached population and make the services more equitable and reached. Yeah, thanks, Ellen.
Thanks, Abriti. Really useful insights. And if I can turn to Abu Conte, Abu from Comas in Sierra Leone. Abu, would you like to share a little about the ARISE framework and how that has helped understand gender and intersectional and gender differences within the context in Freetown?
Good morning, everyone. And my name is Abu Conte from the Sierra Leone Urban Research Center, SLOC. I'm actually stepping in for a colleague, Bintu, who is from Comas. So actually the framework has really helped us in Sierra Leone to understand how gender and intersectionality are deployed within research, particularly within the broader context of structural violence, which actually shapes health outcomes and health seeking preferences that people make. So we all know about the Galton framework, which is, a kind of framework which tries to really examine how structures of power perpetuate inequalities in societies, and then trying to also examine how these structures of power shape differences in terms of health and outcomes. So this is very much important in our research, because we see from the ARISE research that all of these frameworks really apply to the data we've collected over a period, and how these have really helped to shape our understandings about these inequalities. So the structural violence framework and the ARISE framework as adapted now really helps to, grasp some of these health outcomes and differences. For example, it has helped us to ask certain questions around health outcomes by trying to really understand why are certain groups of people are continually excluded from healthcare services, like people living in informal settlements, or why is it that some people are much more sicker than some of the people living within the urban space. So one way we have tried to conceptualize this is that we try to situate structural violence within history, because you can't understand structural violence within history, and it's also understood from context. And that context is also rooted in how society is socialized, how people deploy their systems of education, systems of power to shape the differences that happen within society. So we see it as a form of slow or structural violence that has been happening through physical violence, through implicit symbolism, and that symbolism is really what brings the labeling of people within certain spaces. For example, in Freetown, we hear people talk about people living in informal settlements, and that brings a sense of stigmatization. And then also, it links also to gender. The moment people talk about women in certain senses, they are considered as inferior members of the community. So this labeling and inaction by society to correct these things, in some cases, brings some form of normalization around these things, and then it helps to really make health outcomes much more harder and difficult for certain groups of people. So I'll just talk briefly about two sets of data which we have deployed within this study to understand these nuances in detail. So for example, I have my PhD data, which is around chronic disease and health-seeking strategies. And then also we have the ARISE broader data, which a subset of it talks about the experiences of sex workers. So when you look at the ARISE, my PhD data, for example, it tries to explore the longitudinal structures of violence, which is linked to gender stereotypes and things like that. For example, women living with chronic diseases, a lot of them were found to have been denied access to education just simply because they are women, and then their male or their brothers were allowed to go to school. And so because of that, they have lacked a long period of opportunities in life, lack of education, low prospects for income, and then there's continued violence and stress, and this leads to chronic diseases within those settings, like hypertension and things like that. And because of their income levels, it makes it difficult for them to access healthcare, and particularly because of the spaces in which they live. So it's a constant pattern of exclusion which links to certain groups of people. And then worst of all is the fact that the state's response to chronic disease is very almost negligible, because priorities are not linked to providing services for people living within those settings. So when you look at it from an intersectional point of view, it kind of envelopes different levels of vulnerabilities. For example, being a woman, being low income person, being unemployed, and having poor health outcomes, all of these increase the vulnerabilities from an intersectional point of view. And then finally, I'll just talk briefly about the Arise sex workers experience. It also links to, the structural violence and then the implicit violence around labeling of women who are in sex work. And a lot of these women come from rural areas escaping from poverty. They migrate to the cities expecting a good life, but then they can't have good life because they are probably not connected or maybe not in the right places. And they experience violence from the police while doing their work. And there's neglect from the state to protect them. And despite this, the fact that they are providing services like sex work, but they are stigmatized in different spaces, including having access to healthcare. So Mike, I'll just end by just trying to ask, how can we meaningfully deploy, the framework of equity linking to intersectionality, structural violence and gender, to be able to understand the different layers of vulnerabilities that happen within the informal settlements. So thank you so much.
Thanks, Abu, and apologies, definitely from Slurk, not Comas. I do apologize for that on the slide. And thank you for those reflections. We are getting very tight on time and I want to go around everyone. We did want to also hear if panelists had key recommendations for funders, for policymakers. So can I ask the remaining panelists, if you have a kind of burning recommendation that you want to add, please do add it as you're answering my next question. So I'm next going to go to Adrita, who's been working with the Arise team in Bangladesh. Adrita, could you explain how these frameworks have helped you understand intersectionality and gender within the context in Dhaka? And please do add any recommendations for policy as you're speaking. Thanks, Adrita.
Hello, everyone. This is Adrita Rahman from Bragg James Cyprian School of Public Health, Bangladesh. And in this part of the session, I will discuss our case study on female-headed households in informal settlements in Dhaka. So by female-headed households, we mean households where women are either widowed or abandoned, or they're separated or divorced, or have no male earning members. And these women are the sole earners and decision makers in the family. What happens is that we basically notice that there's a complex interplay between poverty and power relations and the gender dynamics that results in these women in female-headed households in slums to experience high levels of vulnerability when we compare them to men. And these women are solely responsible for earning money and for taking care of the family. And as a result, what they do is they prioritize their family's needs over their own health when they fall sick. Between buying food for the family and paying rent and bills and children's tuition fees, they do not prioritize spending their limited income on paying doctors' fees and buying medicine for their own health conditions. They have, their visibility and their mobility vary, and they also face greater harassment, late at night, and are more discriminated against. What we also saw through our, field work is that the longer waiting times in public hospitals mean that women from these female-headed households would need to forego the opportunity to earn wages as normal informal workers who are not, as they've been working as informal workers, who are not entitled to have sick leaves or any paid leaves and are under the constant threat and worry of losing their jobs. To ensure that their family members are well fed, often these women from these female-headed households, what they do is they cut down on their portions and reduce the number of meals, the frequency of the meals that they take. That can lead to greater instances of malnutrition and adversely affect both their physical and mental health. We also noticed that women in these female-headed households who do not have families and live near, and who do not have families that live nearby, or have family members who are better off than themselves, have lesser support in terms of the social support networks, and they also hold less power and have lesser access to resources when compared to their male-headed households that we can draw a comparison from. And this in turn influenced their health-seeking behavior. For instance, during COVID-19 lockdown, what we noticed was that when reliefs were distributed, these women from female-headed households had no, specifically those who had no son in their house, could not receive that aid, not only because these queues or these lines were dominated by men, and also because these men often tend to have a better connection with the local leaders when compared to these, women from female-headed households. And I think with that, I feel that that would give you a picture of the intersectionality and the gendered impact that these women face. So thank you so much.
Thanks, Adrita. And moving on quickly, I know we're running out of time, and thank you to the panelists who are responding to all the Q&As, because we may not have time to talk those through, because I'm very keen to hear from all of our panelists. So if I can now turn to Chinyere. Chinyere, can you describe to us some of the impacts within the context where you've been working in Enugu and Onitsha in Nigeria?
Okay, hello, Helen, thank you very much. So very quickly, I would like to reflect on an interesting finding that is coming out of a preliminary analysis from qualitative interviews with informal providers in urban slums. So actually, when we started out with the framework and trying to do the gender and intersectionality analysis, our interest or focus actually was on the end users or service users. However, in interacting with the informal providers, we began to see a pattern in access to resources among informal providers that is influenced by gender and intersectionality. So I'll just share an experience we had, or the case of a particular informal provider, a woman who had a patent medicine store. However, she's a nurse, she's a trained nurse midwife. And the reason why she opened the patent medicine store is because she couldn't get a job in the formal sector. She couldn't get employment in the formal sector. So one interesting pattern that we're finding is that among these informal providers, you will find that the patent medicine vendors, for instance, are mostly men. It's a male-dominated practice. Meanwhile, the traditional birth attendants is a female-dominated practice. And we also are finding, patterns with respect to level of education among these informal providers appear to have more education. They have access to more information. They have access to more networks than the traditional birth attendants. And we are finding this interesting because we would like, or the end goal of our project is actually to institutionalize linkages between informal providers and the formal health system. And while we are going to come up with some criteria for determining eligibility of informal providers to be linked, into with the formal health system, some of the criteria that we are going to be coming up with, we need to be careful. So what we are actually becoming more sensitized to is the need that is the need to be mindful in how we describe and apply the criteria that we will eventually come up with, so that we do not in the course of trying to create services that are of better quality to people in the urban slums, that we do not through our intervention propagate any gender differences or imbalances in access to resources, particularly for the informal providers, so that in the end we are not having like it's the it's a particular gender, because they already have access to resources and they would be more likely to meet our eligibility criteria. And then the other group of informal providers, the other, would then not, meet the criteria, and then they keep, just staying there. So, I mean, that's just what I want to share, an interesting bit of work and how we are actually thinking about how to take it forward with designing our interventions and implementing them. Thank you.
Thank you so much, Chinyere, and great to see that the analysis on the supply side in terms of providers. And we're really running out of time. So for the remaining 4 panelists, please do just keep to a very brief insight. If I can now turn to Ivy, who has been looking at these issues within informal settlements in Nairobi. Ivy Chumo, please do add your contributions.
Thanks, Helen, and thanks everyone for joining. I am here in Nairobi, Kenya, at African Population and Health Research Center. I also am part of the ARISE team. And briefly, I am going to speak about the child head of households, and just to reflect at a personal level that you can imagine being a child and being uneducated and being poor and living in an informal settlement and heading a household. So that's the context of most child head of households who are living in the informal settlements. So they face all kinds of challenges, and COVID-19 and any other emergency exacerbate their vulnerability and marginality. And for them to seek healthcare is very challenging, especially the fact that they are children. They depend on adults who are not there for them, and they lack the education that anyone would need to think, and the fact that they lack the ties. So the few things that drives or their health-seeking behavior, the first one is their societal demands. Traditionally, the society would support children and they would be treated as wealth, but contemporary society, the society that we live in the informal settlement, most times children are taken as a burden. So they lack somebody to lean on. When they are sick, they just stay behind at home. They don't have that capability to think that they need to look for antenatal care services. So they just stay at home, and the condition can even make them to die. There's some child head of households who've been dead recently because of some issues related to their inability to seek for healthcare services. The second bit of it is their biological and physical needs. They have so many unmet needs. And the fact that their children, they're poor, they're uneducated, they live in the informal settlements, and most services are informal, including the informal healthcare that exists. They end up depending on anyone around them to offer consultation on their health services. So there are many cases, or one instance, for example, where the child-headed household, their children, so they relied on their neighbor to offer drugs for eye ache for their children, and the child ended up being blind in the long run because they used drugs that was already expired, and they got advice from incapacitated person. They didn't have the capacity to diagnose someone for the eye, or even to recommend them to seek a better health service. The last bit of it is the institutional invisibility, that these children lack a voice. They don't have a voice. Remember, they are children. They are seen as mini adults, so they are treated as children. They should be depending on adults, but no adult is available to support them. So in the long run, they lack a voice, they lack somebody to represent their voice, and the policies or the institutions are not representing them, including the policy agenda. So with those, for our case, for that case, we recommend that there's a need to treat children as children and not mini adults, and that they should be reflected in any policy agenda or any other agenda. Thanks.
Thanks so much, Ivy, and really helpful to hear those intersections. Very quickly moving on to Lauren, who's been working with the chorus team from the University of Ghana. Lauren.
Thanks so much. So I'm just going to touch briefly on the Ghana's CHIPS program, which has been the focus of Chorus Ghana's work so far in Ghana. And I'll talk a little bit about the gendered perceptions of the program and then the relationship with policy status and other issues. So the CHIPS stands for Community Health Planning and Services Initiative, and it's a national policy that places nurses in communities to work with them to achieve the objectives of providing basic primary health care. And the nurses are supported by volunteers who liaise between the health workers and community members and support activities like community outreach and home visiting. So the CHIPS policy has been scaled up nationwide, but its testing was initially piloted in rural areas and a lot of focus was placed on maternal and child health indicators. But according to the national policy, the CHIPS is to support both men and women across all stages of the life course through activities. And it's supposed to be adapted to the unique needs of each community through nurses and communities working together. Our findings so far from our needs assessment in Ghana show that in urban areas, there are some challenges that are faced in delivering the program, including the limited number of nurses, logistics, and the limited understanding of the community about the program, as well as the difficulty of sustaining volunteers in an urban context. And this reduces the ability to actually implement like a true life course approach and also to adapt the program to urban areas. So the CHIPS program, as it's implemented in these settings, caters a lot to maternal and child health and sexual reproductive health. And the community has a perception that it's mainly for women. So there's a need to find ways to engage other populations, including men, and to consider the unique health needs. So we are considering that because, as was mentioned, chorus involves co-production. So we are currently trying to brainstorm with communities on ways to address these issues. Thank you.
Thanks so much, Lauren. And yeah, I think this really highlights this need to not just transplant health systems and services and programs that have worked in rural areas, and really thinking about how to adapt them so they respond to these kind of urban challenges. So thank you so much. Partho from the George Institute in India has been working with Arise. Partho, would you like to just talk through how you've used the frameworks, and if you could try and keep it very brief because we are almost
yeah.
Thank you.
So the context is that I work with migrant waste workers in India, and most of these waste workers are driven to urban areas, mostly from agrarian distresses, natural calamities, and large-scale displacement. Displacement happening from large-scale developmental projects. And this also drives their vulnerability in the urban areas, in the sense that when they seek healthcare, they are often denied services based on the discriminations they face at the hospitals that comes out of their caste locations, the sort of work they do, because waste work involves a lot of associations with purity and pollution. And there have been cases where the waste workers have been denied healthcare services, especially in the public hospitals. There's also the additional element that within the villages, there are these networks of middlemen who encourage, or who rather convince the villagers to go to particular public facilities in the urban areas, against which these middlemen, of course, get some commissions. So there is this always this networks of middlemen involved in informal settlements who are working in, who influence people to seek private healthcare services. And then when we want to shift gender norms and promote inclusion and diversity, we must also understand that governance systems are not always keen to work with the most marginalized people, because depends on the larger political economy, as well as the sort of what sometimes simply derives their political commitments. And then formalization is always not on the agenda of governance systems. It's very difficult to work with informal waste workers because it is the informal waste workers who are sort of subsidizing the urban systems in terms of waste collection and the entire waste management ecosystem. And my brief recommendations to policymakers will be to strengthen and fund the public health system, particularly the primary healthcare system. And for funders, it would be that we need a very, working with informal workers, particularly migrant workers, needs a very long-standing commitment. So we need a long research cycles. So we need a sort of a long-standing funding. So that would be.
Thank you so much, Partha. Really valuable insights, and thank you for those recommendations on policy as well. So finally, I do appreciate we're a little bit over time, but I hope that a lot of you can stay, because I just want to turn to Sushama Kannan from ARC Foundation to talk about some of their work in Dhaka with the transgender community in particular. So yes, Sushama, over to you for the final word.
Thank you so much, Helen. So in Bangladesh, our project was about strengthening urban primary healthcare system to deliver essential non-communicable disease care. And to explore the context in our need assessment phase, we collected data from both urban primary healthcare providers and the community surrounding the urban primary health facility. So we found that there is difference in male and female in terms of accessing and providing care. However, the particular findings that I'd like to talk about is how the third genders receive primary healthcare services in urban areas and how they're provided services from the perspective of supply side of health systems. And according to Morgan framework, these findings fall under how the values being defined and what constitutes power relation among different social strata. So our qualitative findings showed that the transgender community within the city face discrimination at the health centers. It was found that there's a huge stigma across the healthcare providers and also other clients regarding the third genders. Both healthcare providers and the members from the third gender community reported it. So the participants from the third gender community reported that the staff often, the healthcare staff, they often has told them that they should not attend the facility because it will upset other patients. In addition, the staffs, they also feel uncomfortable and they prefer them not to come to the clinic. The reason is they're afraid that there may be a dispute and lots of arguing if the transgender patients are waiting in the waiting room. So they're often told to be seen either the last or they're deprived of treatment. One of the third gender respondents, they reported that he did not get access to enter a private hospital when he went there with a sister because of his gendered identity. They also told that usually they prefer to use pharmacies or the drugstore, those which are near to the slum areas where they live, as they know the pharmacy owners and the drugstore people usually show them more understanding and empathy, whereas they do not get treatment at all or being treated rudely from the maximum healthcare facilities. And because they face so much stigma and they are pretty much neglected, consequently, they hardly attend other family healthcare centers. And when we talk to healthcare staff, they also say that they do not get to see many third genders, only one or two of them visit the facility once in a while. Although the healthcare providers told that they treat the third genders equally, but they also pointed out that how other clients become upset to see them in the premises and wonder why those group of people goes there. And in that case, they are not interested to take services from that clinic as well. So to recommend for policy making, I think it's a long-term, it needs a long-term plan because people's mindset will not change so quickly. So there should be some provision of healthcare service that the transgender community, the third gender community can access. And there should be long-term plan to change the people's views and stigma around the community. Yeah, that's all. Thank you.
Thanks so much, Sushama. I think really valuable insights into a very under-researched area, and just great to have that collaboration and involvement of the transgender community in Dhaka in the work that you're doing. So thank you so much for sharing that. I apologize that we have gone over time. There have been some brilliant questions coming up in the Q&A, and I can see that panelists have been busy responding to those. So please do have a look at some of those answers. We will be sharing the recording of this on both the Arise and the Chorus websites. So please do take a look as well at some of the case studies and blogs and papers that have been published by both consortia, because I think they really bring some good insights into many of the areas that we've only had a chance to really touch on in this webinar. But I think really fascinating to hear how valuable this kind of analysis can be in really understanding and unearthing the kind of inequities that are being seen in urban contexts, particularly in informal settlements, and understanding how these gender and intersectionality characteristics are being transformed, and social norms and gender norms are changing within the urban context. And that does in many ways leave a lot of room for kind of optimism that there can be progress, and this kind of addressing some of the discrimination and the health systems challenges that we're seeing, in the kind of structural violence that has been highlighted within Arise as well. So I think urbanization can lead to changes and can move things forward and progress. And I think these kind of insights that we're getting from this research can really help us to move forward in that direction. So thank you so much to all our panelists for sharing your insights. I'm sure that everybody listening will be really excited to see some of those insights coming out in various outputs. And please do keep checking the Arise and Chorus websites for more details of all those outputs. So a very big thank you to all the speakers and the panelists, and to all of you participants for your great questions and your involvement in the session. It's been a really fascinating but too brief, but great. And thank you everyone for joining. So I think we will sign off now and have a good rest of the day. Okay, thanks everybody.